Good afternoon, everyone. Michelle Casada here with WPTV. We are talking about the latest developments from the FDA on monoclonal antibody therapy. And as you can see, many of the centers are closed already today, or all the centers across the state are closed today. You can see that picture on this side right behind you. We took at the Westgate Recreation Park and Center where monoclonal antibody therapies were being given at the time. Now it's closed. And I'm bringing in a local infectious disease specialist, Dr. Larry Bush. Dr. Bush, thank you for joining us this afternoon.
Thank you. It's my pleasure.
We have a lot of questions and we're trying to get all those answers for our viewers today. If you do have a question, please feel free to comment it, to type it into the comments, and we'll get to it. Dr. Bush, the main question we're getting from people is, if their appointments were canceled for Regeneron or any other monoclonal antibody therapy they were supposed to get today, what is the option? Can they go to their doctors, their medical providers, and let them know what's going on? Is there another way to get these treatments?
So right now, the only approved monoclonal antibody for treatment of somebody who's been diagnosed with mild to moderate COVID and meets a mild or moderate risk factor, doesn't require hospitalization, is one called sotrovimab. And that's because the Regeneron's been known for quite some time that it was active against Delta, but it was not active against Omicron. And since Omicron makes up greater than 90% of all the new cases that we're seeing throughout the country, as well as right here in Florida, it's been removed by the FDA because it's not effective, and it will keep people from getting a potentially effective monoclonal. Unfortunately, sotrovimab is in short supply. Now, hospitals are still being distributed sotrovimab, and that's where it would be the easiest place to get it if you were diagnosed with COVID and if you have symptoms that are mild to moderate and you have some type of underlying risk factor. That could be obesity, diabetes, renal disease, heart disease, lung disease. So the sites don't have enough of it. It doesn't warrant them to be open. But keep in mind, there's also the antiviral medication, Paxlovid, and the Merck medication, molnupiravir, that are starting to be distributed both here throughout the country and here in Florida. That's another option.
Which those are also in very short supply. I saw in Palm Beach County, I think we only have one Publix that carries it right now on Military Trail in West Palm Beach.
That's correct. So that's also in short supply. So the recommendation still for people is to make sure you're vaccinated and have a booster. And if you do get diagnosed with COVID, most likely you're going to do fine and have a mild disease. But if you have mild to moderate disease and recently diagnosed and you have an underlying risk factor, you should try to get sotrovimab. Again, the easiest place to call around is to your local hospital, see if they have it. You'd have to go to the emergency room.
Today we heard the governor say that he thinks this is a very bad move. He says that even though these types of treatments weren't showing up to be, 90% or 80% effective against Omicron, that they did help some people with their symptoms, that there was some sort of benefit to this. Dr. Bush, what do you say to that? Is there any harm in getting these monoclonals, even though they weren't going to be 100% effective, like we saw, the high efficacy with Delta?
Well, first of all, when you give somebody a monoclonal antibody and they start to get better, you're assuming it's the monoclonal antibody, where we know that the majority of people will start to get better after they've been vaccinated or have had prior infection without the monoclonal antibody. But it does show there are no studies looking at Regeneron with Omicron. But what we do know is there's not a reason to think it would work for Omicron, and that's why the study's not done. So in essence, if you go get it because, quote, it can't be harmful and it may be beneficial, has no proof, and it can give you a false sense of security and keep you from getting something that has a potential of being beneficial.
And I just want to reiterate for those just joining in, I know someone asked what's going on. We're talking about the monoclonal antibody therapy centers. All the sites across the country really have been ordered to be shut down by the FDA because the FDA has removed authorization for use of the Regeneron and another type of, which I can't pronounce it. I'm sure, Doctor, you can. You say it hasn't been used around here for a while, but another type of antibody therapy as well. Those authorizations have been removed because the FDA says they're not proving to be effective against the Omicron variant. I do want to get to a comment. Dodie Cole commented, I had the I'm assuming she means the monoclonal antibody therapy, and I believe it saved my life, as after the infusion, I was admitted to the hospital with COVID pneumonia and a heart attack. Have you seen that these treatments, doctor, have been very helpful to people, even after we've seen the Omicron variant across our area.
Well, it's possible that they had a Delta virus and not an Omicron virus, because when you get tested, the test doesn't tell you which variant you have. It just basically says you have COVID-19. It could be any one of the variants. And we'd like to think, and I'm glad she got better, that it was the effect of the monoclonal antibody, but you can't disregard everything else that was given to that patient in the hospital that may have had the major effect. Um, and these are individual cases, but overall, it's felt that this would not be very effective. And again, it may keep people from getting something that has a much greater chance of being effective.
Christy wants to know if you, doctor, are using any of these treatments or prescribing any of these treatments to your patients.
Well, I don't have it available because it's only being distributed to places like hospitals, but people who have mild to moderate disease and meet the recommendation of who may benefit from it, I recommend that they go to the hospital to get it. Before, when Regeneron was felt to be helpful for Delta, I would recommend going to one of the sites. Obviously, that's no longer an option. Regeneron's not recommended. It's been withdrawn by the FDA. You know, everybody gave a lot of criticism to the FDA for authorizing things before there were full studies. We should also look at that now and say that they've now taken it back, because now they've done what everybody said they weren't doing, having more data. And with the future, you know, with the data that they've now, you know, accumulated, they're taking it back because they're saying, yes, now we know this isn't helpful for Omicron. So that's a good job on their part.
And I'm glad you mentioned the data, Dr. Bush. You know, we've heard our governor say that this data is coming from a study that was done in a lab and not a clinical study. Has there been more data or more studies done since the initial announcement was made that it may not be as effective against Omicron?
No, but the same reason that if an analogy be, if you had a urinary tract infection with a bacteria and my drug in a test tube had no effect on that bacteria, it would make no sense to expose you to that antibiotic. There'd be nothing to think that why it should work in you. The same idea with this monoclonal. If it cannot inhibit the virus in a test tube, it's not going to inhibit the virus in your body.
Yeah. And I know a lot of people have been questioning, you know, why there hasn't been a lot of information put out. I know this notice came out just yesterday from the FDA, even though the FDA had put a pause on Regeneron shipments to states back in December. We saw that. I want to run a quick clip from our health department director here from Palm Beach County, Dr. Alina Alonso, where she does talk about, you know, what's going on right now and why high-risk patients, they should be trying to find the FDA approved, or right now the ones that are approved to be administered.
We have to look and see what we have here and make sure that people are still, I mean, they're not going to give us, they're not going to be giving the therapy that's not approved. So they will make their changes accordingly so that people can get treated with the right monoclonal therapy. The monoclonals work on all of them. So yes, if you are in a high-risk category, you should go get your monoclonal therapy to avoid going into the hospital and or dying, right? So that makes sense. The therapy works that way. So
Okay.
don't worry. It's Omicron. 99.5% of everything out there right now is Omicron. So even if it's Delta or even if it's something else, they all work against it. So anybody who is high risk should get the monoclonal as a prevention.
So, doctor, that clip a little bit contradictory to what we're talking about. You were saying that even if you're high risk, if you get monoclonal for Omicron, it's not going to help you. It's not going to do much. That's what the FDA is saying. Do you agree with that statement?
Well, they're saying the Regeneron one. I think what's happening here is I agree with Dr. Alonso fully. What she's saying is that the new monoclonal antibody, so Trivimab, works against all the variants, Delta and Omicron. And the Evusheld, which is the preventive monoclonal antibody, works against all of them, Delta and Omicron. So those are the two options right now. Treatment would be Trivimab, prevention would be Evusheld. Regeneron has no play in this any longer. Now, the FDA knew that a while ago, and that's why they stopped using it. But the people who still had it in supply were still using it. Now they basically said, we do not authorize utilization at all.
And Mary is asking, how do they know which strain you have when they test you? And to my knowledge, doctor, they don't, not with regular testing.
On an individual basis, if you go and get tested right now, for instance, and you test positive, I can't tell you what strain you have. Nobody can. But the state and the federal government do surveys constantly. And when they take a random sample, what they found is, like Dr. Alonso said, 95 to 99% of all the tests right now that they randomly sample are Omicron. So if you had to bet which strain an individual has, it's 95 to 99% chance it's Omicron, it's not Delta. And that's how they make that determination.
And someone asked, I think I lost the question, but someone asked, doctor, do you know which hospitals currently have the correct antibody, monoclonal antibodies that are allowed to be used?
I believe that the majority of the hospitals in Palm Beach County, of which there are 14, have the monoclonal antibody. The problem is it's in short supply. And on any one given day, they could be out waiting for their next shipment. What we need is the Glaxo, the company who makes it, to hopefully step up production and distribute it. The AstraZeneca product called Evusheld is a preventative monoclonal. That's before people have become infected. That is specifically aimed at people who may have gotten the vaccine, but the vaccine wouldn't be expected to work in them because their immune system is so weak. Maybe they've had a transplant, maybe they're on medications that really dampen down their immune system. That's a prevention. That's not for people who've been recently diagnosed.
Okay, so those are for immunocompromised or people doing cancer treatments or another treatment that would suppress their immune system where the vaccine wouldn't normally work for them, or they haven't been able to get vaccinated, or the antibodies haven't come through with their vaccine that they can get Evusheld. Is that
Exactly. And that's what Dr. Alonso is alluding to, is that both of these monoclonal antibodies, one for prevention, one for treatment, are effective against all strains. Regeneron is not effective against the strain that's making up all the disease we're seeing now.
so? As of right now, what would you recommend people do if they are sick with COVID, they're positive, they may have an underlying condition, they want to get the correct monoclonal antibody therapy? Is this a call to your medical provider? Is this a call to your local hospital? How can someone set this up?
You're better off calling your local hospital emergency room and asking them one simple question. Do you have sotrovimab available? Do you have the effective monoclonal available if I come there? And if they say no, you have to move on to the next emergency room. Option B is try to find the antiviral medication. And as you said, it's in very short supply. And that's been the issue all along here. The FDA and the scientists and the pharmaceutical companies have done a great job. It's the distribution of these things, the availability of them, which is lagging behind. And that's nobody's fault. It's just the way it is. The unfortunately, demand has clearly outstripped the supply faster than one would have expected.
And, Perla's comment, you see it on the screen right there. She said she got the monoclonal antibody therapy 10 days ago. So she may have had Omicron and it made a big difference in her recovery. She's also autoimmune compromised. So these are the types of scenarios, doctor, where you say it's helpful.
Well, yes, and we don't know which monoclonal she got. If she got it at the local, state site, she probably got Regeneron. And yes, she would like to, and I would like to think that the monoclonal helped her. But on the other hand, it may have been a previous vaccine. It may have been just the body's way of fighting the virus, and the monoclonal antibody had nothing to do with it. None of us can really tell her that. Fortunately,
Yeah.
she got that.
She says it was not Regeneron. She says it was specifically for Omicron and Delta. So I'm assuming that it was the GlaxoSmithKline antibody
Exactly.
you're talking about.
And that's great. That's fortunate. That's a testament to that monoclonal antibody.
We're talking about the treatments available. Still, the COVID antiviral pills are a huge, you said mentioned before, a huge game changer. Still very hard to get, but do you feel like once we boost up production and distribution of these, that antibody therapies will kind of be a thing of the past?
Yes, I think once there's an antiviral for people who've been vaccinated and has felt that the vaccine likely worked because their immune system, as far as we can tell, is normal, the antiviral is the way to go. It's much more easily taken. You can take it more quickly. You can get it more easily at a drugstore. One other thing I want to mention, the remdesivir intravenous antiviral that we heard so much about at the beginning, that's also made, that we were only giving to people in the hospital by infusion 5 days in a row who were severely ill, has now been proven to be effective if you get it early on, within the first few days, 5 days, that you just get 3 infusions one day after another. That's an antiviral like taking a pill, but infusion. The problem, once again, is you can't get that as an outpatient very easily. It's difficult. You would have to be in a hospital. But that's another antiviral taken early on that has been now shown that you don't have to wait till you're very sick. So that's another option. And we are doing that. We are doing that in the hospital.
In the hospital setting, but there isn't a way to just get remdesivir infusion unless you've been admitted to the hospital.
Well, some infusion centers are starting to get this because it is an FDA approved drug. You just have to be able to secure it from the pharmaceutical company. And infusion centers who do routine infusions for chemotherapies or antibiotics have a way of getting this, and some of them are doing this. Your own doctor may be able to direct you to one because there's a host of infusion centers throughout the county.
Now, doctor, one of the questions I had today for these centers is, some of these centers have been getting daily allotments of the supply. Others may already have some on hand. Is it wise to just let this stuff sit there, or I mean, at this point, if it can't hurt you, at least you can try it and see if it helps you in some way.
You're talking about the Regeneron.
Right, the Regeneron, right.
In essence, that would make sense. It can't help, it can't hurt you. It always potentially can have a side effect. But the way I look at it, hurt you, is it keeps you from getting something that more likely is to help you. Because if you get that, you're going to feel like, well, let me see how this works. And the fact is, it likely won't be helpful. And if you're somebody who's going to progress because of your underlying condition, you're not going to have the opportunity of getting something that will help, either sotrovimab or an antiviral medication, a pill, or early remdesivir. So I would not recommend it. And that's why the FDA withdrew it. Their main goal in our country is not to harm you. Yes, they'd love to help you, but they don't want to harm you. And I think they look at it that if they allow Regeneron to go on, they potentially harm you because it keeps you from going to get something that can help you scientifically in the laboratory.
So in this case, if you get Regeneron and you have the Omicron variant, you're creating a false sense of security where you'd be stopping yourself from maybe trying to get the antiviral pill or remdesivir or something else that could potentially help you feel better.
Exactly. And that's why they withdrew it. The FDA's job is safety, right? It's a prescriber's job to decide if it's beneficial for you. They felt that it's no longer safe to give this based on what I just said.
Are there any, you mentioned side effects. What are the side effects of getting the Regeneron antibody therapy that could be, not harmful, but, you'd be going through the side effects for no reason because it's not going to help you?
Well, you're taking a synthetic material and putting it into your body, just like people are concerned about getting a vaccine or side effects from a antibiotic or an antiviral. In essence, you can react to it. And there are. Now, fortunately, in the studies, they've been very limited and very mild. But I think the biggest side effect is the false sense of security, which is not a medical side effect, but an emotional side effect.
What are the challenges you're seeing right now, Dr. Bush? There's a lot of treatment options out there for COVID-19. We know the vaccines are obviously the best way to go when it comes to not spreading the viral load of the vaccine, but the vaccine is not preventing COVID-19 either. Realistically, we have to address that. So treatment options are right now what people are looking at when they do get COVID, but how hard is it to even get your hands on a treatment for COVID-19?
Right now, it's very hard because sotrovimab, the monoclonal antibodies, in short supply. The antiviral pills are approved, distributed, but in very short supply. And the remdesivir takes, difficulty getting 3 days of infusion. But I think that's going to change. Now, let's talk more about the vaccine. There's no doubt about it that people who've had boosters make up the minority of people who advance to being hospitalized. They also make up the minority of people who are getting COVID. So the third booster clearly is more beneficial to people who've had two vaccines, both in preventing COVID and being hospitalized or getting ill. I can't overestimate the boosters. And in fact, only about 39% of the people who can get boosted have gotten boosted, which is a small number. Most of the countries in the world that are boosting have a much higher number. And even in Israel this week, they came out and showed that in people over 60 who've had a fourth vaccine, that's even added benefit. And I know people are sick of hearing about vaccines, but if they work, they work. And we can't deny the facts, the data that's out. There were 220,000 people looked at recently with Omicron, and those who had booster had an advantage in every which way: getting infected, getting sick, being hospitalized, and dying. Clear advantage, 3 vaccines over none, over previous infection, over 2.
How do you get that message across when you have, a large population of people that have lost their trust in the vaccine, seeing people that got vaccinated and are still getting infected? I know we say that if you get infected with the vaccine, you may have, more mild symptoms, but mild is a relative term. As we know, what's mild for one person is considered more severe for another in their mind, in their perspective.
They have to look at the data such as I'm telling them and say, when you look at 250,000 people with Omicron and you compare previous infection to vaccines versus booster in every category, getting infected, getting hospitalized and dying, every time the booster wins by a large amount, a large amount. So, you can't ignore that. I could tell them you can say whatever you want, but at the end of the day, the score of the game is 10-1. You lost. The end of the day, there's the scoreboard. I mean, look up at the scoreboard.
And Doctor, I want to go back to something you said earlier too. You mentioned that for those people who have most likely gotten the Omicron variant, because that's the most predominant one in our area right now, and got the monoclonal and started feeling better, you said it's likely that they would have started feeling better on their own anyways. We know the Omicron is less severe when it comes to symptoms compared to some of the other variants we've seen. How many days after contracting the virus or the first day of symptom are you seeing patients start to feel better on their own anyways with the Omicron variant?
The people who've been boosted, I'm seeing them get better in 3 days. I have a colleague the other day who called me Saturday. She just tested positive. She had a high fever, sore throat, and a cough Saturday. Yesterday evening, she said, I'm totally better. Vaccine. No monoclonal antibody, no antiviral. And I'm seeing that over and over and over from patients I talk to, their families and colleagues. What I'm seeing admitted to the hospital, the people I'm personally taking care of right now, have had no vaccine. They're making up the majority. And the next group are the people who've had 2 vaccines. I've had very few people who've had any hospitalization with boosters. I have had some, but they're getting better quickly.
And what about the people who have had previous infection for COVID-19? Are they still seeing benefits to previous antibodies when they contract, if they contract?
They are, but the people who've had previous disease and then got vaccinated do better than the people who just had previous vaccine. Yes, excuse me, previous disease. Previous disease gives you natural immunity, but in essence, you're adding to that natural immunity by getting a vaccine afterwards. So it's just another layer of protection. It's not an all or none. It's a layer of protection that you can't argue against. You can't argue against the scoreboard, like I'm saying, at the end of the day. Look at the groups: no vaccine, previous vaccine 2 times, vaccine and booster, previous disease. The winner every time is boosted, 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 every time.
Yeah, and I just want to reiterate to people, Dr. Bush has been a part of the clinical trials and the investigative studies with AstraZeneca. He's been very involved in COVID-19 and vaccination for COVID-19 since early on, since we even started investigating a vaccine. So you obviously, doctor, have a lot of knowledge on how the medicine and just the entire science has evolved in how we learn more information on this virus and how the vaccines work against it.
Yes, and I appreciate you saying that. And again, I'm not a shill for any of the vaccines or the companies. I'm basically a believer in the data, and that's the data. I mean, that's true data. The people who do the studies have nothing to gain from saying that.
Anything else you'd like to add, before we close out? Today, Dr. Alonso mentioned that what you said recently, that we're now entering this endemic where now we're just treating this virus and learning to live with it. We've kind of have all the tools in place that we needed to kind of get to this point. What do you say to that? How can people continue to protect themselves? How can people continue to live with this, knowing that, it's going to be a recurring situation with more variants to come?
I think that should be encouraged to know that the vaccines are safe overall, statistically, that they are beneficial, particularly the booster, that testing is going to become available easily at home right away now. As you know, you can go on the CDC site and order your 4 free tests, and they're shipping them out as we speak, and that there's antivirals going to be available soon. That doesn't mean you should go out and say, well, that's it, the masks are done, or the social distancing is done. Common sense is common sense. We just have to make it a little bit more common and not be so against when somebody says perhaps this would be beneficial. I don't find it offensive if somebody says maybe you should wear a mask when you come in here. I don't take offense to that. I don't look at that as a something encroachment on my freedom. I look at it as somebody's looking out for me.
Thank you, doctor. And I just want to remind everyone again, so the monoclonal antibody therapy state sites that were open, those are now closed today until further notice. We do know the FDA has removed authorization for the Regeneron and other types of monoclonal antibody therapies that they say have not proven to be effective against Omicron. We're going to have much more on this story today on our air, WPTV at 4, 5, and 6. And online, we talk about, with Dr. Bush, where you can get these, the approved medications, how you can go about finding out which hospitals have them. And of course, we'll be talking about supply. What happens to the Regeneron that's out there now? Where does that go? So we'll have all of that later on today. I thank you all so much for joining us, for asking questions, for posting comments. And Dr. Bush, as always, thank you so much for your time.
Thanks for having me. It was nice
All
meeting
right,
you.
everyone, have a great day.